Bismillahirrahmanirrahim. I am Dr. Akif and today we'll be discussing the management in adults. So this is the roadmap that we'll go through. First thing first, case definitions. As already been discussed, a suspected cholera case is when an outbreak has already been declared, any person presenting with diarrhea or dying of watery diarrhea is a suspected case. And you can confirm by doing the culture and PCR, but one do not need to confirm each and every case. Once an outbreak is reported and a diarrhea is reported to you, you need to treat them the same way, whether it is cholera or not, except that in severe cases you have to aggressively hydrate them. So these are the cases. A 25-year-old gentleman presented in the emergency department with watery diarrhea for 1 day history, and there are 5 to 6 episodes per day. It is not associated with fever, vomiting or abdominal pain. On examination, patient is alert, conscious, vitally stable, and there are no evidence of dehydration. Such patients need to be treated at home with ORS. The case to 48-year-old gentleman with a comorbid, that is diabetic on oral treatment and he is a smoker, presented in ER with profuse watery diarrhea for 12 hours. And here you can see that the frequency of stool is 10 to 12 per 12 hours, and these are large volume stools associated with vomiting, decreased urine output and difficulty in breathing. On examination, patient is irritable with sunken eyes, skin pinch goes down slowly, blood pressure on the lower side, tachycardia, and there is decreased urine output. So this is one of our patients that presented us with acute diarrhea with severe dehydration. You can see the patient is listless with 2 IV lines. And these are the picture of our patient. You can see that there are sunken eyes, anxious look on the face of the patient, and he's got dry coated tongue. So this is how a severe, moderate to severe dehydration will present to you, and one need to identify these patients by the look of it, that these are anxious looking patients with sunken eyes, decreased skin turgor and dry coated tongue. So volume status holds the key in the management of cholera. So one need to assess the degree of dehydration, and WHO has divided into 3 categories. That is a severe dehydration. One look for the danger signs, that is lethargy or unconscious patient, absent or weak pulse, or respiratory distress. If anything out of these 3 is present, they are admitted, and these are a severe dehydration category with a history of diarrhea. Or at least 2 of the following 3, that is sunken eyes, not able to drink or drink poorly despite being dehydrated, and then skin pinch goes back very slowly, more than 2 seconds. Then this term that WHO has coined, it is some dehydration, that is, it is lesser than the severe, but there is dehydration. In these patients there is no danger sign, and at least 2 of the following may be present, that is irritability, restless, sunken eyes, rapid pulse, thirsty, and these patients drinks eagerly. This is the difference between the severe, that despite dehydration patient is not keen to drink, is not able to take orally, and then skin pinch goes back slowly but not very slowly as opposed to severe. And then the third group is no dehydration, despite the fact that this patient has also got diarrhea and volume loss, but there is no measurable dehydration in these patients. So these are awake, alert, normal pulse, normal thirst, and these needs volume replacement, but with oral and at home can be managed. So how do these patients present? As already been told that 80% of these are asymptomatic, and mind you, these asymptomatic patients are shedding the bacteria in the stool, so they can spread the infection. So symptomatic patients are 20%, and out of these 20%, only 20% of these 20% are moderate to severe volume depletion, and these needs admission. A typical patient, as already been discussed, present with diarrhea, sudden onset painless watery diarrhea, vomiting, abdominal cramps, and then manifestations of dehydration. What are the signs one needs to look at in emergency and OPD? Weak thready pulse, tachycardia, dry tongue, decreased skin turgor, sunken eyes, hypotension, and that if hypotension is left untreated, that can lead to shock, drowsiness or altered sensorium. So what are the complications that we are already talking about? Who is vulnerable to complications? The children with severe malnutrition, elderly patients, and those who have got some comorbid illness like diabetes, hypertension, congestive cardiac failure. These are the high risk patients. So what are the complications that are likely to act? Volume depletion can lead to acute kidney injury. Ongoing volume losses can lead to hypokalemia, and hypokalemia is not corrected, that can lead to paralytic ileus. One needs to note that in patients with congestive cardiac failure, if these present, one need to be very careful and judicious in replacing the fluid, as these patients can lead to pulmonary edema. So case management, how do we manage them? Global Task Force on Cholera Control in collaboration with WHO has given the guidelines and we are going to discuss them. First of all, I would like to say why cholera is different from other infectious diarrhea. Because there is severe volume depletion to the tune of 5 to 10% of the body weight. And this loss is very rapid, typically 10 to 10 ml per kg per hour. And then with the greater volume losses, the electrolytes loss is very tremendous. Without treatment, cholera can kill 50% of the patient with severe disease. So we need to identify the severe disease and treat them aggressively. Otherwise, there is 50% mortality in severe group. So what are the errors that we do in managing these patients? We underestimate the amount of fluid lost. So one need to be very careful in picking up the signs of dehydration, and use of incorrect fluid, that is non-isotonic fluid, should not be used. The preferred fluid is ringer lactate. So WHO has divided it into three categories. One is non-volume loss, that is less than 5%. In these patients, volume loss is there but is not measurable. If it is a suspected case of cholera and there is diarrhea, the weight loss, the volume loss is less than 5% of the body weight, and it has been described as none. And then some is 5 to 10% of the body weight is lost, and then severe more than 10%. So what are the principles of management? Aggressive volume repletion is the mainstay. Replace fluid orally initially, except in patients with severe volume depletion. In mild to moderate depletion, one can replace them by oral ORS. May it need at home therapy or during hospital stay, but one need to replace the fluid orally initially, except in severe cases. Antibiotics in patients with some to severe volume depletion, that is those who are admitted, or in cases of epidemic, one can adjudicate that antibiotics may be given. This is the concept that WHO has given to manage the cholera epidemic, that cholera cots these are inexpensive, and you can see the bucket under each cot. So you directly measure the volume lost in the stool and you add this volume to the basal replacement. In the absence of cholera cots, continuing losses can be estimated to be approximately 10 to 20 ml per kg per stool, that is roughly 800 to 1500 ml per stool, and this is in addition to the basal losses that patient has presented with. So this cartoon is important that in management, that you categorize them to the degree of dehydration. So we start with the first one, that if it is severe dehydration, you need to admit the patient, and you need to replace more than 100 ml per kg of the volume, and that will fall into plan C, that we'll discuss later on. Then some dehydration, that some we have already discussed what is some dehydration, and these should also be admitted to the hospital, and we will follow the plan B that we will discuss. In this type of patient, we will be replacing 50 to 100 ml per kg. And then no dehydration but diarrhea is there, volume loss is there, you need to manage them on OPD basis, and the volume replacement is less than 50 ml per kg. So what is plan A? Plan A is oral rehydration of patients with no signs of dehydration. This patient does not need admission to the hospital. You need to tell them that take the ORS at home, replace the fluid in the tune of 50 ml per kg body weight, and add the ongoing losses, that is 50 ml is the basal, and you see that if he passes 10 stools per day, then you need to add this loss to the basal fluid, and you replace them at home. And in case the condition deteriorates, when do we say that the condition has deteriorated? If the patient has repeated vomiting, if the number of stools has increased, if the patient is not drinking or eating, then he needs to report to the healthcare facility. This is important that one needs to know how the ORS is prepared. The water should be the safe water, and one needs to use it within 12 hours. Once prepared, use it within 12 hours and at max 24 hours if refrigerated. ORS sachet is available, widely available, so it can be prepared easily. So what is plan B? Plan B is oral rehydration for patients with some dehydration. That is the category B. All these patients should be admitted. These are the patients which can go into the severe dehydration. So these should be admitted, and oral or rehydration plan of 4 hours should be instilled. That is 75 ml per kg in the first 4 hours is given. This is roughly a liter an hour. So in 4 hours you give 4-5 liters of oral fluid, And if there are continuous losses, that is, patient continues to have diarrhea, you add these losses to this 75 ml per kg to replace them. And these patients do not need IV therapy but need to be monitored closely during the first 4 hours. 4 hours के बाद आप इनको reassess कर लें. If severe vomiting or not able to drink or signs of severe dehydration appear, then shift to plan C, that is IV medication. If there are still signs of some dehydration and the patient is improving, you can add another package of this 4 hours with 75 ml per kg and then reassess at 4 hours. If there are no signs of dehydration after 4 hours, that patient has improved significantly, taking orally, you can send this patient to home on oral therapy. So replacement of fluid volume for patients with some volume depletion, that is some volume category. This volume replacement, as already taught, is in the tune of, let's say, 3 to 5 to 7 liters that patient has to take orally during admission in 4 hours. So then comes to, if patient does not improve on oral replacement during hospital stay, then shift them to plan C. What is plan C? Plan C is medical emergency and patient must be admitted and treated urgently. Seconds can make a difference, as these patients can go to renal failure and multi-organ failure. So more than one IV line must be taken. Start IV fluid immediately. What is the choice of fluid? Ringal lactate as physiological isotonic is the preferred fluid. If in an epidemic state, ringal lactate is not available, you can use normal saline and dextrose saline, but do not use dextrose water. It is not recommended. So give a total of 100 ml per kg ringal lactate solution in first 3 hours. So 100 ml per kg in first 3 hours, that can be divided into 2 segments. First segment is 30 minutes. In 30 minutes you have to replace 30 ml per kg. That is almost 1.5 liters in first 30 minutes. And then in the next 2.5 hours you give 70 ml per kg fluid. That amounts roughly in 70 kg patients almost 5 liter. So in 3 hours time you give 100 ml per kg in severe dehydration patients, and followed by another 100 ml per kg in next 19 hours. So in 24 hours you give almost 200 ml per kg, and it may go up to 350 ml per kg if the patient deficit is not being corrected or there are ongoing losses. So once you give such hefty amounts of fluid, one needs to monitor them closely. So how do you monitor? Volume status should be addressed through physical examination, that is pulse, capillary refill time, blood pressure, skin turgor, and this should be done more frequently in severe depletion, that is every 15 to 30 minutes patient should be reassessed. And after 3 hours, once you complete the quota of 100 ml per kg, patient hydration station, if it is improved, then patient can drink, and then you can switch to plan B. If a severely dehydrated patient comes, you give them 100 ml per kg, that is 6 to 7 liters in 3 hours. You reassess, patient has been taking orally now, you can switch to plan B. The rate of fluid depletion can be increased if volume depletion is not improving. Once the fluid volume to replace the estimated initial deficit has been administered, patient should be managed on the estimated degree of residual volume depletion. So what is the role of antibiotic? Antibiotics are indicated in patient hospitalized with some to severe hydration. That is, all admitted patients should be given antibiotics, and patients with coexisting conditions like pregnancy or comorbids should be given antibiotics. What is the advantage of antibiotics? It shortens the duration of diarrhea, it reduces the volume of stool by 50%, and it lessens the duration of shedding of Vibrio cholera. So in epidemic conditions, it helps in reducing the spread. So which antibiotic should be given? Antibiotics usually are given in oral form. You hydrate the patient, and once they start taking orally, give them orally antibiotics. And what antibiotics are there? First line is doxycycline, 300 mg per oral single dose. And the alternates are azithromycin 1 gram or ciprofloxacin 1 gram. And as Dr. Amna has mentioned, in cases of resistance, you can switch to whatever susceptibility is there. But generally, it is, in our setting, it is susceptible nicely to doxycycline and azithromycin. So use them. These are cheaper and simple. Oral can be given orally as opposed to carbapenems, which has to be given IV and are expensive. So when do we consider discharge? Consider a patient for discharge if he has no signs of dehydration, if he is taking orally and tolerating the ORS, if he has no watery diarrhea for the last 4 hours and is able to walk without support and is walking and is passing urine. So pregnancy is a special group which are at high risk of fetus loss has been reported in patients with pregnancy. So antibiotic treatment should be given to all pregnant ladies, and one need to be very careful in assessing the volume in pregnancy patients, especially in third trimester. And the use of oral cholera vaccine as a preventive measure is considered to be safe and is recommended in pregnancy. So this is a cartoon which is summarizing what we have talked already, that if there is significant volume depletion, categorize them as severe, some or none. If it is severe, immediately admit and replace the fluid. If it is some, admit but give them oral fluids and monitor them. If they improve, you can discharge them. If does not improve, you can switch to plan C, that is IV medication. And then no dehydration, you can manage them at home with oral ORS. So take home message is assessment of hydration and volume replacement is the cornerstone of management. Thank you very much.
Thank you, Professor Akif, for giving very clear messages, the importance of assessing the volume. Most of the patients will be managed at home with ORS, and only selected patients need admission and antibiotics. Now we move to the next speaker. He is Professor Fahim Afzal. He is Professor of Pediatric Medicine